I have to introduce Associate Professor Sara Tomassetti, who originally or informally now is the head of Interventional Pulmonology Unit Department in Careggi University Hospital in Florence. And she's going to talk about an exciting field for pulmonology today, which is interventional pneumonology, and talk about novel data in this area. Mrs. Tomassetti.
Good afternoon, everybody. Can you hear me well? Yes. So first of all, I want to thank the organizers and the chairs for this invitation. Truly honored to be here and to share some data about interventional pulmonology. I will try to touch both ILD and COVID-19 topic related to interventional pulmonology, starting from novel data on ILD diagnosis. And then we will see together what changed in the interventional pulmonology unit during the pandemic era. We will see the role of PAL basically in the diagnosis of COVID-19 patients with negative non-invasive testing. And finally, I will conclude briefly with a couple of slides on the possible role of transbronchial lung cryobiopsy in COVID-19. So talking about the role of interventional pulmonology in ILD diagnosis, we cannot mention the BAL that has been and still is used in the diagnostic algorithm of interstitial lung disease in many experience centers. And that has had a role also during the COVID pandemic, and we will talk about it in the next slides. But more interestingly, I want to underline again the concept that Venerino has already masterfully explained in the previous slides, that interventional pulmonology, particularly EBUS and EUS, in the last 20 years has overcome the use of surgery, surgical biopsy or mediastinoscopy in the diagnosis of sarcoidosis, because interventional pulmonology compared to surgery is less invasive, less costly, and similarly accurate, as shown in the many papers that Venerino has summarized before. And what happened for sarcoidosis in the last 20 years is now happening for lung biopsy in diffuse parenchymal lung disease with the venue of transbronchial lung cryobiopsy that in many experienced center is substituting surgical lung biopsy. The evidence is in favor of transbronchial lung cryobiopsy comes from this robustly designed clinical prospective trial that showed that the accuracy of transbronchial lung cryobiopsy in the majority of cases, 60%, in which the multidisciplinary team could reach a high confidence diagnosis was high, and no need for surgery in this subset of patients. Whereas in the subset of patients where the confidence of the diagnosis was...
Sara, you need to share again your screen because we lost.
Yeah. Let me do this again. Can you see it again?
Yes.
Yes, we can. Okay. Okay. So in this study, the majority of high confidence diagnoses were concordant with surgery, and in the minority of cases in which the multidisciplinary team after cryobiopsy couldn't reach a high confidence diagnosis, surgery was added meaningful information in a minority of cases. So it is clear that when the diagnosis is confident, we don't need surgery, but when the diagnosis with low confidence after transbronchial lung cryobiopsy. We are in a gray area where, in my opinion, we need more data and more study to address what is the true utility of surgery. About standardization, Venerino and many other interventional pulmonologists have done a lot. We have a wide position paper, and we have recent ACCP guidelines that have shown how to standardize the technique. And right now, currently, the technique in expert centers is well standardized. There are 3 things to remember. To perform safely a cryobiopsy, you need the bronchial blockers, the fluoroscopy guide, and to choose correctly the optimal sites in order to minimize the risk of bleeding. In terms of impact of the information that transbronchial lung cryobiopsy has in the multidisciplinary discussion of cases, we have recently provided this data that shows that the diagnosis of IPF made by the MDT after transbronchial cryobiopsy compared to non-IPF, patients had a significantly worse prognosis, meaning that transbronchial lung cryobiopsy carries significant prognostic information similar to those of surgical lung biopsy. When we add the biopsy information to the initial clinical and radiological scenario, what happens is that histology and the discussion of the case with the pathologist changes the initial diagnostic hypothesis in approximately 1/5 of cases. And we have shown that in the cases that are pathologically reclassified, the prognosis is worse compared to non-IPF cases, meaning that in the initial diagnosis of non-IPF made by clinician and radiologist, and then followed by the reclassification to IPF, as you can see in the red line here, prompted a correct IPF diagnosis and avoiding a misdiagnosis of non-IPF. The change in the diagnosis is not the only relevant information provided by biopsy, because we know that cryobiopsy and surgical lung biopsy have also another role, that is in the subgroup of patients with confirmed diagnosis to increase the confidence of the team in their initial diagnostic hypothesis. And the combination of these 2 factors, from one side, the change in the diagnosis, and combined or with the increase in diagnostic confidence, changes the treatment approach in 1/3 of patients, meaning that after knowing the biopsy results, the MDT is less inclined to wait and watch, more inclined to treat with antifibrotic and immunosuppressive treatment, depending on the underlying diagnosis, and less inclined to use steroids only. So cryobiopsy and surgical lung biopsy provide histology data that do have a significant impact in patients' management. In this pandemic era, the activity of interventional pulmonology has dramatically changed. We know that all elective procedure and all diagnostic procedures in ILD patients were postponed in our hospitals. Main indication for diagnostic bronchoscopy were suspected malignancy or tuberculosis in ascertained non-COVID cases, meaning cases with a clinical and radiological picture suggestive of an alternative diagnosis and negative non-invasive testing. Most of the activity in interventional pulmonology revolved around COVID cases in the last 2 months. Of course, bronchoscopy and particularly BAL was used to confirm COVID diagnosis in suspected cases with negative non-invasive tests. And in positive COVID-19 cases, diagnostic procedures were avoided or postponed following the International Society bronchoscopy guidelines, and bronchoscopy was mainly used for mucus plugging aspiration or secretion aspiration in patients with lung atelectasis or respiratory failure. Therapeutic bronchoscopy, of course, continued to be guaranteed. The environment, the setting of the endoscopy changed dramatically. We increased our personal protection equipment in all cases, and particularly in COVID cases, we had a dedicated endoscopy room. We limited the personnel to the essential, meaning one nurse and one bronchoscopy when possible. We used positive pressure, the respirator, full face shields, disposable bronchoscopes, and standard high-level disinfection and air circulation. And you can see on the left, the standard DPI for non-COVID patients, and on the right, the positive pressure respirator to perform safely bronchoscopy in non-COVID patients. In the multidisciplinary diagnosis of COVID-19 in patients with double negative pharyngeal swabs, we decided to perform BAL rather than tracheal aspirate. This was based on biologic rationale. So basically, we all know that the COVID virus binds receptors that are abundant in the alveoli, and the BAL is one of the best techniques we can apply to harvest the microbiome and the virus from the alveolar spaces. There are indirect evidence suggesting that in the lower respiratory tract biologic specimen, the viremia is higher and persists longer compared to specimen of the upper respiratory tract. And finally, several studies from SARS and MERS have shown that BAL has a higher sensitivity compared to other biologic specimen, and this study in COVID-19 confirmed a sensitivity of BAL of 93% compared to 63% of nasal swabs. So we basically had to face two different scenarios. The one scenario in patients with negative non-invasive testing, the first scenario was when the clinical and radiological picture was highly suggestive of COVID-19, and the role of BAL in this subset is still under debate because, in fact, it probably doesn't really change the allocation and the treatment of the patients. We all know what are the typical features clinically, laboratoristically, and the HRCT features of COVID-19, and when we face a typical case, the indication of BAL can still be based on the fact that nucleic acid detection is still considered the gold standard for the diagnosis, that currently we do not have robust studies addressing the diagnostic accuracy of the sole clinical radiological diagnosis in the absence of nucleic acid confirmation. It can help to rule out other infection, to detect a specific pattern, and last but not least, BAL can increase our knowledge of the disease in specific research protocol. Of course, contra the use of BAL, there are concerns about the safety for patients and for the staff, because we know that BAL is an aerosol generating procedure, meaning that it should be limited. The setting in which BAL had the highest role was for sure the setting of intermediate or low diagnostic likelihood of COVID, and here BAL really made the difference both in patient treatment and allocation between COVID and non-COVID diagnosis. All common differentials, meaning bacterial, atypical, and viral pneumonia, drug toxicity, other ILDs, vasculitis, opportunistic infection, and other more rare entities, can be diagnosed with the use of, with the help of BAL information. Therefore, in the differential of those conditions, BAL had an important role. And just to share a couple of cases, this was a 55-year-old female who presented at the emergency room for desaturation, acute dyspnea, but no fever, and was interpreted by the rapid evaluation team as COVID, but the non-invasive testing were negative. We and the thoracic radiologists were called as expert team for COVID diagnosis, and in fact, the clinical, serological, and BAL profile secured a diagnosis of antithin-A syndrome and excluded COVID infection. And another case in which we were confident that quite confident that this was not COVID, because the patient had chest pain and the typical CT appearance of parapneumonic effusion, but in fact the BAL was positive for COVID-19. So this was in fact a complication of a COVID infection, meaning that we really need to understand what is our diagnostic accuracy as a expert clinician and radiologist, and what is the added value of BAL in this setting. Exploring this, we are performing a study. We have enrolled now a couple of hundred patients, and these are some very, very preliminary results that shows that BAL was positive in about 1 patient out of 10 with negative non-invasive testing, and that with the increase of the confidence of the multidisciplinary team, we also have an increase in the specificity of the diagnosis. Finally, only 2 slides about transbronchial lung cryobiopsy and COVID-19 patients. I'm not sure I can show this because this is not one of my study, but this is a Venerino Poletti study that, as far as I know, is the only center that has implemented the use of cryobiopsy in early and acute phase of COVID-19. And I'm sure that we will have terrifically interesting data helping us to understand the pathologic features and the pathogenesis of this disease in the early phase, because we have many autoptic studies, but the features are completely different. And finally, a proposal. This is a national multi-center protocol that is currently under evaluation, in which we are proposing to follow patients with HRCT and BAL and cryobiopsy in order to understand better what are the radiologic and pathologic correlation in the patients that will develop post-COVID fibrosis, and what is the natural history of this unknown entity. So in conclusion, transbronchial lung cryobiopsy provides reliable histologic data and is currently integrated in the ILD algorithm of many experienced centers and accepted by the ACCP guidelines for the diagnosis of ILDs. The pandemic era has profoundly changed the interventional pulmonology settings, and some change I suspect that will become permanent. Experts in ILDs, interventional pulmonology, and thoracic radiologists had a central role in the diagnosis of suspected COVID-19 cases with negative nasopharyngeal swabs, and transbronchial lung cryobiopsy will help us probably in the future to better understand COVID disease, post-COVID fibrosis, and possibly other ILDs pathogenetic mechanisms. Thank you very much, and I want to thank you for your attention, for your invitation, and all the young people working with Venerino and working with me in Florence for their strenuous work in the COVID pandemic and in the research field. Thank you very much.